Hello and welcome everyone to Kidney Conversations. Thank you very much for joining us, and I would like to hand over to our host for today who will kick us off. Thank you everyone.
Thank you very much, and good afternoon to everyone. It's lovely to see so many people joining this Kidney Conversations, and it's wonderful to see so many supporters of Kidney Research UK. Before I introduce myself, I'd just like to do some basic housekeeping first. As you may have noticed, the meeting is being recorded, so that will be available for people joining this conversation just now, but also for people who've registered but are unfortunately unable to join us live. They'll be able to watch this later on. The other basic housekeeping, as I'm sure most people will be familiar with, is to try and keep yourself muted. With regards to your video, feel free to either keep your video on or off, and that's completely your choice. With regards to questions, we'll be very keen to try and make sure that this hour is as interactive as possible. We've got 3 excellent speakers, and any questions that you may have, please just put them into the chat box. We'll try and answer as many of those questions live, and if for some reason we can't answer it live, we'll try and answer it later on for you. With regards to myself, my name is Adnan Sharif. I'm a consultant nephrologist at the Queen Elizabeth Hospital in Birmingham. I've been a consultant for about 10 years, and my research interests are mainly transplantation, but I also look after dialysis patients as well. I have a few other interests with regards to research. I look at long-term outcomes after transplantation, but also have an interest in increasing organ donation in Black, Asian, minority ethnic communities. And I also sit in the steering committee for Give a Kidney. Because of those reasons, I've been associated with Kidney Research UK for a number of years as a trustee. It's been wonderful to see some of the work that Kidney Research UK has done in a number of these areas, not just in transplantation, but working in dialysis, kidney disease in both adult and pediatric communities, and in some of those underprivileged communities. And focused on the work that Kidney Research has done, we've got 2 excellent researchers who will be talking about some of the work that they are doing that Kidney Research UK has supported. Our first speaker will be talking about the impact of COVID-19 on the kidney community, especially with regards to kidney transplantation, and she's been at the forefront of the research that's been done to try and protect our kidney patients from the impact of COVID-19. Our second researcher will be talking about some of the research that she's been doing, supported by the charity, with regards to dialysis treatment options in our pediatric population. And in between those 2 researchers, we've got the perfect person who bridges those 2 speakers, a patient who has experience of both dialysis as a child due to the onset of congenital nephrotic syndrome, but also her experience with regards to her kidney transplants that she's received. So without further ado, it gives me a great pleasure to introduce our first speaker. Dr. Michelle Willicombe is an honorary senior clinical lecturer at Imperial College Healthcare and an honorary consultant nephrologist working at the West London Renal Transplant Centre. I think it's fair to say that Michelle's been at the forefront of a lot of the research that's been done looking at the impact of COVID-19 and vaccination with regards to our kidney failure population, both dialysis and the transplant community. And it's a great pleasure to get her insight during this conversation about some of the work that she's done that's been supported by Kidney Research UK, and especially her latest project called Melody, which has been supported by a number of charities, including Kidney Research UK. Michelle, pleasure to have you on.
Thanks, Adnan, and good afternoon, everybody. So Adnan's already introduced me, and normally by background, I'm a transplant nephrologist and researcher, but my work has very much been diverted to looking at COVID in kidney and immunosuppressed populations since March, April 2020. And we, my team, have been involved in a lot of local as well as the national studies. First of all, we were looking at the immune responses to the virus in kidney populations, and then we progressed to looking at vaccine responses. And we've been involved in the Octave Duo, and we're recruiting to the Kidney Research UK supported Protect V study as well. But the 2 particular studies I want to highlight are those that have been spearheaded by the support from Kidney Research UK, which is the NAMI study, and then my own study, which is the MELODY study. So it became quite clear early on in terms of the vaccine rollout that kidney patients, and especially those that were immunosuppressed, weren't going to be responding as strongly to the COVID vaccines as people who are otherwise healthy with no underlying medical problems. And Kidney Research UK, certainly, I think, because of the impact that COVID had on certainly the in-centre hemodialysis patients the first time round, we wanted to try and assess the efficacy of the vaccine within this population. And Kidney Research UK supported the NAMI study, which is a study looking at the antibody responses, or particularly the antibody responses called neutralizing antibodies that develop after vaccination to help protect people against COVID infection. And these neutralizing antibodies are the things that are thought to be most predictive at protecting against infection. And we've had 2 publications to date, and this is over 10 different centres have taken part in the NAMI study, which is supported not just by Kidney Research UK, but several kidney patient charities around the UK. And it's providing some very useful information that perhaps the level of protection afforded by the 3 vaccines in the dialysis populations may not quite be as strong as people with no underlying health conditions. I'm going to move on to talk really and then next about the MELODY study. So from our local data, we established that following 2 vaccines, our transplant population, only about half of them were making any antibody responses at all to COVID vaccines. And we were very glad to hear that the 3rd primary doses were rolled out for these immunosuppressed patient populations. The data shows that perhaps the people with the highest level of immunosuppression, so patients who have solid organ transplants, people with autoimmune disease who are on therapies directed against antibody development, and people with blood cancers are perhaps the most the patient populations that were reported less response to the vaccines. So although this population is now on 4 vaccines, what we want to establish as part of the MELODY study is what proportion of immunosuppressed patients have detectable antibodies after 3 or 4 vaccines. Data that's coming out of Imperial this week will show we have estimated, having looked at 700, that about 25% of transplant patients don't have any detectable antibodies after 3 vaccines. So it'll be important to establish how many will have antibodies after 4 vaccines. So what the MELODY study is doing is we are aiming to recruit 36,000 of these most immunosuppressed patient populations, 12,000 organ transplant patients, and then 12,000 each of the other cohorts. At the moment, the MELODY study is open for transplant recipients to opt in by themselves. So anybody can visit the www.melodystudy.org website and are able to opt into this study. What it will involve is that when you log in to the website, it will ask you to register. You need to register with your NHS number and date of birth. And it will ask you some basic information to make sure you've had the 3 or 4 vaccines and about what immunosuppression you're on. And then you will get delivered at your home address an antibody kit, which is a finger prick test to look for antibodies. Now, this home test isn't as sensitive as some of the one tests that you can have within the hospitals, but actually what it will detect is people who have good levels of antibodies, which you want to know. So once you load up your results once you get your home test, you do the test, load up the results, and there's further questions to ask. And what we aim to do is to be able to define how many of these patients have detectable antibodies, and then following these patients up over a 6-month period by data capture, be able to see whether or not the lack of people who don't have any antibodies are at higher risk of infection and poor outcome. Because the question really remains is that within all the different populations within the UK, but certainly within the kidney population and transplant population, immunosuppressed population, there is a range of responses to vaccines. And I think I think in order to inform further management of patients, perhaps doing antibody tests on patients to see whether or not there's a response to guide further management strategies might be a good thing. And this is what the Melody study is going to answer. And it also asks for feedback with regards to what people and patients want. So would you like an antibody test? Does it make you more anxious to know your antibody status or not? And then it asks some other questions regarding COVID risk and behaviours, etc. So I think it's going to provide very useful information and perhaps a way of tailoring ongoing management to inform immunosuppressed patient populations moving forward. And we're hoping the first set of results will be posted as soon as recruitment has finished. And we're still in the recruitment phase, but the uptake and enthusiasm for patients to take part, and actually what we feel from feedback, know their antibody status after vaccination, has been quite high. I'm happy to take any questions regarding Melody or any other thing related to COVID research. I don't know, Adnan, if there's been any questions.
There have been questions, Michelle, and thank you for that. And frankly, I'm always kind of wondering how you manage to kind of combine all your research with the day job that you have as well. So, so absolute credit to you. So there's a couple of questions that were already asked before. But there's one that's been posted in just now, and someone's asking that if they've participated in the Melody study and they did the test after vaccine 3, but they've now had vaccine 4, will they have an opportunity to do another test?
Not at the moment, but actually that's what we would like to do. So we haven't got the approval to give a second test out, and we haven't got the additional kits, but I would be very keen to do that. So watch this space. If you have taken part and that becomes available, we will be contacting you.
Excellent. One of the other questions that's been put in is how long will the recruitment stage take approximately? So I guess maybe you could give us an idea as to how far you've got with regards to your recruitment. Yeah,
so I think because the recruitment is happening slightly differently. We've been reliant to the different cohorts. We've been reliant on approvals, etc., for the sending out sending letters to patients to take part before they consent. So there's been a number of hold-ups with that, but we're finally through those, and we believe that our Melody study is based on what's called the REACT study, which is it was a REACT-2 study, which was a similar study done in the general population. And actually, recruitment only took 4 weeks when the letters got sent. The transplant population are slightly different because we know that all transplant patients are on immunosuppression. They can have an opt-in. The reason for letters is to make sure that the other populations are on specific therapies of interest.
Excellent. Well, one of the other questions is, does a fourth jab make a big difference? I guess we could answer that by saying that's the importance of your research, and where hopefully we'll be able to try and answer that question, because I imagine for a lot of people that will be the thing that's kind of worrying them, especially that statistic that you mentioned about 25% of the transplant population not having any detectable antibodies after their first few jabs.
Yeah, I think so. I mean, there's already data that's come out of France after 4 doses of mRNA vaccines. Not everybody. There's still a lower percentage than the general population who will have antibodies. But I think so. I think a guide is, if you've had no antibodies after 3, then I mean the question still remains whether or not you develop sufficient antibodies after 4. And there is, there's early data, but to suggest not everybody's going to be as protected as we want. So perhaps we need bespoke strategies for that population.
So one of the other questions that we have is, I mean, what's been the biggest challenge that you faced during your COVID-19 response research?
I think the biggest challenge has been actually keeping out with the changing of clinical guidelines. So Melody was only for 3 jabs, and then obviously then the booster came out for everybody 4th jab. So it's changing that, and it's chasing getting sampling, etc., right times with the changing approvals and JCVI recommendations. And then, as always, in the early stage of COVID, getting research ethics was very straightforward, but it certainly slowed down during the latter period, which was a shame.
And one of the other questions is, how were patients involved in the design of your research?
Well, so for the Melody study, as I said, it was very much, this was in collaboration with Kidney Research UK, who helped us with engagement with other charities, so the Cystic Fibrosis Trust, Vascular Access UK, and Blood Cancer UK. So via those different health research charities, we developed patient groups and insight with regards to the surveys, etc. I mean, universally, I've never been involved in research where I've had patients actively contacting me to get involved in wanting to know their immune responses to vaccine, etc. It's been extraordinary. So I think there definitely was a requirement to do research. It was getting the right research sort of approved and done. And actually, what we should continue to do is further adapt to as the pandemic evolves, and actually what patients want. What do they want to know? What is their research questions for COVID moving forward?
Excellent. So we still have a few more questions. So one of the participants is asking about T cells and what their kind of influence is going to be on this kind of vaccination story. Do you have any particular insight with regards to that?
Yeah, so on the whole, as a rule of thumb, the antibodies correlate to T cell responses. T cells, so while antibodies protect you from getting infection, T cells will protect you from getting severe disease once you've become infected, but really they work together. But the responses on the whole in the general population is that they correlate. So if you've got good antibody responses, you've on the whole got good T cell responses. With the immunosuppressed patients, for example, people that are on rituximab therapy for their autoimmune disease, that therapy targets antibody responses. So a lot of those patients have detectable T cells. So actually, having that T cell data is quite reassuring. Unfortunately, people on transplants, who the most common agents are mycophenolate mofetil and tacrolimus, they target both the T cell response and the antibody response. So they're both quite flat. But it's very important to know in terms of responses, the different agents people on may predict what responses you're going to see.
Excellent. So one of the other questions, and I guess this is probably the most common question will get asked in kind of day-to-day clinical practice is what your advice is for transplant patients who show no antibodies after 3 or 4 jabs.
Yeah, I think this is what we need to lobby the government for as the next step, because they are going to be patients. As I said, we've already looked, not within the Melody study, but sort of locally, we know that some people won't respond to 4 vaccines. And what is the next step for these when it's an end to mask wearing and the end to sort of isolation come March? The Omicron variant, fortunately, does seem to be slightly less pathogenic, certainly even with the immunocompromised patients, but it's not mild. There's no such thing as mild infection. So I do think we should lobby. There is evidence, of course, I haven't seen it against Omicron variant, of the longer acting or the pre-exposure prophylaxis for those patients who aren't responding. And that really is, I think, which the PROTECT-V study is addressing, which should be very important and informative with regards to helping lobby the government for actually a management plan.
Excellent. I've 2 more questions if I can ask you, Michelle, so I can try and keep to time. So one of the questions is, if an individual has no antibodies, does that mean the vaccines have no effect or that they have a reduced effect?
Okay, so that's really interesting. I can't answer between no effect and reduced effect, but there's certainly now, even in sort of a lot of dialysis patients, where probably most widely studied, is that there appears to be a correlation between antibody responses and overall risk of infection. And we know that people, certainly there are a number of case series reporting transplant patients, for example, who have no immune responses after vaccine, who do worse when they, or if they do become infected. So it's all correlation rather than exactly causation, but it makes logical sense that if you haven't gotten a detectable immune response, you're not going to be able to fight off the risk of infection or the disease itself if you contract it, as well as people with normal responses.
Excellent. And one final question from one of the participants. They're saying they took part in the Melody study and they registered positive for antibodies after 3 vaccines, but they mentioned that they also took part in the ONS study, which also is testing for antibodies. And the question is, are both studies testing for the same type of antibodies? And is there any way of calculating the strength of the antibody reaction?
Yeah, so it will be the same sort of antibody. You have to forgive me for not knowing whether the ONS was a finger prick test with the cassette or ones that you send back for processing. It will be good to correlate. The beauty about sort of Melody is that it's a targeted study, whereas the ONS is open across the board. But there will be, I think, even on the Melody study, there is an intensity of the band which correlates with sort of the antibody levels. But if the ONS data measures lab antibodies, then we should be able to extract data in terms of trying to define a cutoff that perhaps suggests protection. Although, as I said, as the different variants come along, it may become, we may need to start again with that level, because certainly Omicron infection seems to be very highly infection. I mean, I been diagnosed today for managed to avoid for 2 years, but with 3 vaccines. It's not, Omicron is slightly different different virus in terms of it avoiding sort of protection against infection.
Excellent. And I guess in the final minute, just Michelle, I guess how would you think, the support of Kidney Research UK, how important has that been for you and the work you're currently doing?
Oh, it was fundamental. The Melody study would not happen without it. It was very much a collaboration. You know, we felt a need, and Kidney Research UK agreed with that need, and then managed to cohort the charity collaboration, and and actually spearhead the MRC funding that came with it. So it wouldn't have happened without them.
Okay, that's excellent. Thank you very much, Michelle, for sharing your work. And I think it's great to see the work that Kidney Research UK has done to kind of support you and other researchers, and research which is hopefully make a big difference to patients. So thank you for your time, and hope you feel better soon. So it gives me great pleasure to introduce our next speaker before our final speaker, the researcher. And I think it's perfect to introduce Afria, who can bridge the gap between not just being a child who is diagnosed with childhood onset nephrotic syndrome, which affects 1 in 50,000 children, and unfortunately for some people can end up with kidney failure. And she's experienced the different types of renal replacement therapies, including dialysis and transplantation. So it'll be wonderful to hear about her experience. Afria, thank you for joining us.
Yes, hello everyone. As you know, I'm Afria, and it's nice to see so many people here. So yeah, as has just been pointed out, I had transplant when I was a baby at the age of 3. I was on hemodialysis before that, and then in 2019 started hemodialysis again, then to eventually get my transplant 3 months ago, which has gone very fast.
So I mean, it's excellent because you've obviously congratulations on your transplant, and great to see you looking so well. I guess you're in a special situation where you've been able to experience both dialysis and transplantation during the pandemic. And so how has the pandemic kind of affected you for your time when you were on dialysis, and how's that changed with regards to you receiving your transplant?
Quite significantly. I know I was very fortunate to get the transplant in a 2-year period, considering everything that was going on. But it did have huge implications on me getting onto the transplant list. I think I started dialysis, and then a year later, I was put on the list for the first time, and then was on it for 2 months, and then it was stopped again. And then I was on it, but I never got a call from that, and was very lucky to have a family member donate to me, which I'm very grateful for. And leading on from Michelle, also, who you've just heard from, I took part in the Melody study, just to kind of get an idea as to what was kind of happening within my immune system. And I think I was quite fortunate in the fact that I took part, I had my 3 vaccines pre-transplant when my immunosuppression was at its lowest that it's like ever been, because it wasn't on my fortic because of the pandemic, and my TAC level was very low. So I think that actually gave me the best opportunity to build up some sort of immune response to the vaccines. So that worked in my favour. Then in terms of, I did hemodialysis the whole time. It was very strange during the pandemic, wearing masks for 4 hours whilst you're not necessarily feeling the best. It just added some of the nausea at times. And of course the kind of nerves, if people were to get COVID within the unit, I was at a small unit for most of the time. So you were kind of put into a side room. Luckily I managed to dodge anything to, as far as I'm aware. But yeah, it's had big impacts, I think. And just kind of obviously the isolation period throughout was very intense but nice, because my parents have retired, so I had kind of that, we just became like a little trio getting through it together, which was actually quite comforting.
Excellent. So I mean, I guess you could probably tell us for hours, but how has life changed for you after you've had your kidney transplant?
It's really weird. I think prior to transplant you kind of think it's this huge constant euphoria, which because everyone says like it's amazing, and yes, I feel so much better and I don't look grey anymore. But it's definitely because you have this kind of huge adrenaline like response, post-transplant. And so for 2-3 weeks, you can do anything, you're invincible, and you just can't stop smiling. Well, that was definitely the case for me. I was all over the place. But you've eventually got to kind of, you know, try and start leveling out. So I think physically, because my transplant fortunately went very well, and the donor also is doing very well. Physically, great, really good. There's less kind of doubt or worry going on, but mentally it is a big journey. Post-transplant, you kind of don't understand the magnitude until you're kind of like 2 months in, and you're like, whoa, what's happened? So yeah, it is really good. I'm very grateful.
Excellent. And you're also part of the charity's Transforming Treatment campaign, which is focused on looking at how we transform the treatment of kidney disease, including dialysis. And I'll be interested to know, what changes have you seen over the last 20 years with regards to the treatment options available?
Well, it's quite interesting because obviously as a baby, the kind of treatment approach is so different to transplantation compared to when you're an adult, because the doses are higher. Like, I was on higher doses as a baby than I am now, which is crazy to me. But you're so vulnerable. And in terms of medication, I haven't seen much difference. The medicines are still very comparable to when I was a baby. And in terms of dialysis, I guess the most ironic point of this is that on my last dialysis session, on the Thursday evening before my most recent transplant, I was dialysed on the same machine that I used to dialyse on as a baby, which made me laugh. It was a throwback for sure. As little Afria would have said, the big blue one, because it was this huge, big thing to like toddler. Obviously now it doesn't seem as big, but it's still significant in size. But I am aware that they are more transportable options now for dialysis, and to fit in your home, and to kind of, if you want to go away, there are options where you can bring it with you, which is amazing. Like, I'm not aware of them being readily available 20 years ago. So I think that's a huge step in terms of making life a little bit more livable and kind of typically normal. I hate that word, but it kind of fits in the best. So I think that's important, but in terms of medication, I haven't seen too much.
And I guess a final philosophical question for you. What changes would you like to see in the future when it comes to kidney research?
I think now I'm back on high dose steroids again, which I've managed to kind of avoid for the recent years in my last transplant. I think a more friendly alternative to steroids would be huge for a lot of people, just because they have such huge impacts, both short term and long term, and can affect a person in so many ways. And of course, I guess this kind of links to the most recent news article on, for example, the heart transplant, and something along those lines to kind of take the pressure off of the reliance on relying on a donor, which is huge. And it's obviously the problem. It's quite a heavy thing to come to terms with. So yeah, I think it would be good to have some sort of genetically modified kidney from whatever that may be, to take that pressure off and also help eliminate the list. I think that would be really beneficial.
Excellent. Well, thank you very much, Afria, for your time. It's wonderful to see you doing so well, and hopefully you get to enjoy the best of your kidney transplant.
No worries. Thank you for having me.
And finally, it gives me a great pleasure to introduce our final speaker and the second researcher, Professor Rukhsana Shroff, who's a consultant pediatric nephrologist at Great Ormond Street Hospital. Professor Shroff works with children with kidney disease and with renal replacement therapy needs, and it's a pleasure to see what work she's been doing with regards to dialysis treatment options for children, with work that's been supported by the charity. So Rukhsana, wonderful to have you with us.
Thank you for the introduction, Adnan. That's very kind of you. And hello, everyone. Welcome and thank you for joining us. What I'd like to do is share some slides with you, if I may. So, sorry, that went a bit strange. Sorry, that's even worse. Just 1 second. I don't know how to work this. Okay, can you all see my screen with the slides? Adnan, can you see this?
Yes, we can see them great.
Perfect. Thank you so much. So improving dialysis technologies, that has been a big area of research for me. I'm Rakshana Shroff, as Adnan introduced kindly, and I'm a pediatric nephrologist at Great Ormond Street. I'll be telling you a little bit about different types of dialysis and the work I've done in this field. So this little girl, as you see, is on hemodialysis, the blood dialysis machine, the big blue one, as Afria told us. And this little chap is on peritoneal dialysis here, showing off his catheter. Now, dialysis in children is quite different to what is done in adults. It's not simply a miniaturization of things for them. It's taking into account the very specific needs for growth and development that children have, and really the nurturing, the nutrition, and the long-term prevention of complications. And our goal is to dialyze them for as short a time as we can and get them to kidney transplant. But the youngest ones, as you see here, are too small for a transplant. And we have to make them grow up to about 10 kilos in size, which is reached at about 15 or 18 months of age before they can have a transplant. Unfortunately, dialysis comes with complications. And even in young children, you see this sort of severe bone disease or rickets with these bent bones and even fractures. This image in the middle is a heart scan. It's a CT scan of the heart. And the white stuff here are the blood vessels that should normally be pristine and not seen as white, but they're full of calcium. And this excess calcium collecting in the vessels is a big cause of death in our patients, with nearly 1/3 of patients, even children, dying from heart disease. Clearly, this is unacceptable, it's horrific, and we have to work to make this, to mitigate this complication. My work over the years has been in defining the burden of cardiovascular disease in CKD through clinical studies and laboratory tests, improving dialysis treatments for children, looking at improving vascular access through which we perform the dialysis, looking at newer imaging modalities, and then comparing the different types of medications we give to patients. Now, don't worry, I'm not going to bore you with all of this all at once today, but I'll talk about these two things which are close to my heart, literally, and which I've been working on over the last few years, importantly funded by Kidney Research UK, to whom I'm extremely grateful for their continued support. Now, this graph here, going from 100% perfect kidney function down to 0 or no kidney function, shows the different stages of CKD, going from healthy onto dialysis. And here in this box, I'm showing you what happens with a good functioning kidney transplant. So a good kidney transplant, working transplant, would give back about 50% of kidney function. On the other hand, the dialysis we do, the short daily hemodialysis 3 times a week in the hospital, or the PD, gives back only 15%. And then it's no wonder that poor patients feel rubbish on it. And really, it is not adequate treatment. Those who can have home hemodialysis, and Afria was mentioning those machines, the portable machines that one can do home dialysis with. But for those who don't have the privilege of home dialysis, there is another therapy. It's called hemodiafiltration, and it's an advanced way of doing hemodialysis, or the conventional big blue machine dialysis, to try and clear out more of the toxins, do it in a gentler manner, and hopefully help the patients feel better with it. Over the last a decade or so, there have been a number of studies in adult patients, and these large randomized trials, as they're called, have shown a clear difference in outcomes, with the red line here being patients on the usual conventional hemodialysis and the blue on hemodiafiltration. And we saw that correcting, oh, this hasn't come out clearly, sorry, correcting for a large number of different complications, the hemodiafiltration patients did better. And in fact, switching just 8 patients from HD to HDF would prevent 1 death per year. With these statistics in mind, and also with some data from children where we saw some spectacular improvement in growth in the children. Now, these are the growth charts we routinely use in pediatrics and to monitor and plot the child's growth. Some of you will remember it as the charts you have for your children in the red book. And we monitor growth of these patients. So you can see some of these children tracking along the lowest line possible here, but then suddenly shooting up in height and shooting up in height velocity, or the speed of growth here. And this is with hemodiafiltration. So with the support of Kidney Research UK, we conducted this study called the effects of hemodiafiltration versus conventional hemodialysis on growth and cardiovascular markers in children. We call it the 3H, or the HDF Hearts and Heights study. We recruited people from 29 centers in 10 countries across Europe. So as an example, currently there are 120 children on dialysis in the UK. And in order to get adequate numbers, we clearly had to go international. And there are a number of outcome measures we've seen, but just one quick glimpse at this. So this chart, this graph here shows blood pressure over 24-hour recordings. The red are the hemodialysis and the blue are the hemodiafiltration. And this is shown as a standard deviation score, so adjusting for their age and gender. Now, to be in the normal range on this, you'd need to be below this dotted line here. And below the dotted line is normal. But here you see that all these people in red, the HD patients, are well above the line and their blood pressure increases over the study period. On the other hand, the patients in blue on hemodiafiltration are many of them are below the line and they stay steadily below, showing that the blood pressure improves and stays better on HDF compared to HD. We also looked at a large number of other benefits of HDF, from their cardiovascular benefits, which were improved. There was reduced inflammation. The treatment was completely safe and it did not affect any of the residual kidney function, if there was any. There was improved growth and nutrition. The bone disease factors improved. And I think perhaps most importantly, the quality of life improved. Now here, this is a 6-monthly questionnaire that our patients completed themselves, and it looks at factors such as headaches, dizziness, cramps, sleep disturbances, pruritus or itching, and restless legs. The darker the color on the graph, the worse it is. And you see that factors like headaches, dizziness, and cramps are really bad in the HD patients, and they're significantly less in the HDF. So HD was a gentler treatment, being easier on the patients. Most importantly, for my pediatric patients, it got them to school, it increased their physical activity, and that was fantastic. And they actually said they felt better. And now, just to go back to the little Afria and her lovely story about the big blue machines. The blue machines were the old machines which cannot do HDF. So when my patients come to dialysis and they see a big blue machine, even the ones who are unable to verbalize it will scream and say they do not want this. They want the white machine that does the HDF for them. And hopefully we have graduated in our dialysis technology through research and through improved treatments. One other very quick thing. Adnan, do I have 2 minutes more, please?
Yes, you do.
Oh, thank you very much. Okay, then I can just tell you quickly about vascular access for dialysis. So here, about vascular access. You see this little girl here with a dialysis catheter in her chest, and this young lad with an arteriovenous fistula. Now, which one would you have if God forbid you needed it? I think I would go for an arteriovenous fistula, really. It is associated with far less complications, far better blood flow, and improved dialysis. But sadly, for the youngest ones, we do need to use central venous lines. These are what the lines look like, and they're placed deep into the heart, into the right atrium, into this area of the heart, going through one of the big neck blood vessels in the neck. And they're, of course, tiny. They're as thin as this compared to one's finger. Now, the blood flow through these lines is crucially important. And what we have seen with our bioengineering colleagues, where they do this technique called in silico, or basically computational analyses of the blood flows through the line in and out, the effect of the different shapes of the lines, the lumen of the line, the tip, the side holes, and you see that the areas of blood flow can be severely affected in some of these patients. And the mere presence of having a central venous line itself affects the flows. We're doing a lot of work in this area now, again through the sponsorship of KRUK, to try and improve blood flows and dialysis and the safety and effectiveness of these lines. And so, to conclude, improving dialysis technologies is crucial and required to improve outcomes in our patients. Hemodiafiltration may be a better outcome, and certainly in our pediatric population, it's improved with better cardiovascular measures, reduced inflammation, improved growth and nutrition, bone disease, and most importantly, the quality of life. And the cardiovascular, the central venous access or CVL lines for dialysis have a high risk of complications, but we can't, it's one of these things you can't live without in a smaller pediatric patient. And we do need to work on improving their design and the flows through them. So thank you very much indeed, Adnan, and colleagues, and all of you here for listening. Thank you.
Excellent. Thank you very much, Rukhsana. And it's wonderful to hear about the work that you've been doing that's been supported by the charity. And I think on a personal level, I'm always in bewildered awe at the work that my pediatric colleagues do. I mean, my youngest, who's 4 years old, I mean, I struggle to get him to brush his teeth for 2 minutes. I mean, I'm not entirely sure how you manage to keep the children on dialysis, and I mean, it just seems absolutely mind-boggling. So real credit to you and your colleagues. We've got time for some questions. The first question that's being posted is there any possibility of HDF becoming accessible to adults?
Oh, it is available for adults, yes, indeed. And in fact, as all the research and treatment started out in adults, I don't know if every center has HDF available, but it certainly more and more centers around the UK do. And there's a very, very good randomized controlled trial going on across several centers to sort of conclusively show, or not show, hopefully show, the benefits and effects of HDF.
And obviously, I look after kind of adult patients, and we do have people who are receiving HDF, so it's becoming far more common. And another question which has been posted is if calcium levels build up when on dialysis, will having a transplant help reduce calcium levels?
This is $1 million question, a very well thought through question, though. I wish I could say yes, but the research at the present time suggests that once the calcium builds up in the vessels, it is difficult to remove, and therefore all of our focus needs to be on preventing it, which means we need excellent dialysis, so that at the end, when one gets to transplant, you get there with good, healthy heart and vessels.
Excellent. One of the questions is, I mean, I guess since you started your career, Rukhsana, I mean, what changes have you seen with regards to dialysis in children?
Thank you. So, my career trajectory is after I became a pediatric kidney registrar. I then did my PhD, which was in about 20 years ago now. No, that's not, about 20 years ago. And then I became a consultant here at Great Ormond Street. Now, in those 20 years or so of my career, dialysis has certainly improved. The dialysis for infants has improved with newer and better machines. And the treatments for older children, not adults, but older children, now includes as a routine an offer to do home hemodialysis and an offer to do hemodiafiltration in center. So in our in-center hospital treated patients, we do hemodiafiltration for all. Of course, we have peritoneal dialysis as well. And the PD or peritoneal dialysis is done at home. It's a very effective therapy. It's particularly helpful in young children when the blood vessels are so tiny and the vascular access is so difficult. And there have been great improvements in the type of dialysis fluid available, the actual treatment technologies. And of course, we, and by we at this time, I mean an international community of doctors and nurses have been developing guidelines, doing more research, and trying to improve our treatment and challenge ourselves to do better as best as we can always.
Wonderful. And one of the other questions is, how have you engaged patients and their families with regards to your research?
Thank you. So I have a very active kids kidney group here at Great Ormond Street with kids and their parents who are wonderfully vocal and active and tell us what they want and demand why it hasn't been done so far. We also have a group called the YPAG, or the Young Persons Advisory Group at Great Ormond Street, and these are young people from with different types of chronic disease who are again a very, very good sounding board. So in fact, as we even try and think of some new research ideas, we take it to our group and say, hey guys, what do you think of this? And, do you think it'll benefit? And how should we tweak the study? And then, of course, they ask me the most practical questions to catch me out. Is this a big, fat, ugly medicine I have to swallow every day, or is it something I can manage? And are these medicines and formulations a child can take? What are the blood samples and tests you need to do? Are they really essential? How often will you do them? So they're a fantastic group to steer us and take us through, hopefully to help improve treatments.
Wonderful. And I guess at a personal level, how has the pandemic affected you and your research, and I guess also your clinical activity as well?
Thank you. It's not. Thankfully, it's not been as severe or bad as it has been for the adult nephrology and adult hospital colleagues. We have actually had quieter times in pediatrics, as you will have, of course, read in the press. Fortunately, children are less severely affected, and in that sense, our patients have been safe on the whole. From our cohort of nearly 180 transplant patients at Great Ormond Street and about 60 dialysis patients, although some have developed COVID, they have not had any severe infections. And in fact, none have so far had to go into intensive care even. Thank you. The research side has been slowed down and affected, but it's a small price for keeping everyone safe.
Excellent. And I guess I've got a couple of minutes for one final question. I guess I'll just be interested to know what you think is on the horizon, say over the next 3 to 5 years. What do you think will be the big priorities with regards to research when it comes to, say, pediatric nephrology?
Excellent question. There are so many areas in my field of dialysis and improving kidney and bone disease in children. I think developing more sensitive tests in order to be able to diagnose things earlier. And then, as I was saying in response to one of the questions, the prevention of harm before we need to say, oops, you've got calcium in your vessels, now what shall we do? So we're trying to develop tests to prevent this earlier, treat it better. There are new drugs on the horizon and new medications we are trialing as well. And finally, this area of dialysis technologies, which is fascinating. And I'm working on that with my biomedical engineers to try and improve the technologies and therefore the outcomes eventually for people. Thank you.
Excellent. Thank you very much for your time, Roxana, and for sharing the work that you've been doing. Thank you.
Thank you.
I think on behalf of everyone, I'd like to thank both of our researchers, Dr. Willicombe and Professor Schroff, for sharing their research that's been supported by the charity, and it's wonderful to hear the work that they've been doing trying to help adults and children living with kidney disease and kidney failure. And it's great to see that the research that's happening is going to directly change people's lives. It's also a pleasure to hear from Afria and to hear her story, which I think bridges the two researchers that we heard from, her life as a child with kidney disease and kidney failure, and her experiences on both dialysis and transplantation, and wish her well for her new transplant, and hopefully a slightly more rosier 2022 compared to the last 2 years that we've had. We have 5 minutes left. Amazingly, we've been spot on time, so I'm going to give myself a virtual gold star. I would just like to finish off just by updating you with regards to some of the things which are currently taking place. The charity currently has a survey which they're encouraging kidney patients to fill in, which is very much focused on mental health and the support that is available. And your responses would be very important as the charity lobbies government to try and ensure that there's more services available for people who are suffering with kidney disease. Just to remind you also about World Kidney Day, which is on the 10th of March, 3 days before my birthday, if you fancy sending me a present. And we'd strongly encourage everyone to do anything that they are keen to host at work or at home, as we try and raise money and hopefully try and find further ways of transforming treatments for the nearly 850 million people globally who are affected by kidney disease. And the final thing is that information about these activities and all the other work that the charity does will be available in emails to you, but are also available on the charity's website. I'd just like to finish off by thanking all the speakers. I'd like to thank all of you for participating. It's been a pleasure hosting this webinar, and hopefully look forward to seeing you all soon. Look after yourselves and take care. Thank you.